Hello everyone, my name is David Nelson. I'm a research fellow in the Lincoln International Institute for Rural Health here at the University of Lincoln. I'm going to be talking to you today in this short pre-recorded video for the HSR UK Conference 2022 on some work we've done in collaboration with Lincolnshire Partnership NHS Foundation Trust. And this has been looking specifically at staff experiences of using telehealth to deliver the IAPT service. Unfortunately, I can't be at the conference, but my co-author, Ojali Yusuf, who's our Health Education England Population Health Fellow, will be there and will be presenting the poster and rapid oral presentation on behalf of our wider team. So firstly, in terms of some background to this work, well, the pandemic's resulted in a major transformation in how health and mental health care is delivered. So we've seen this shift from a mostly face-to-face model to one of virtual interaction via telehealth. So in response to changing policies, as well as the ongoing situation and the longer-term fallout from the pandemic, mental health care providers now need to make decisions about the delivery of telehealth services in the future. And it should be noted that there was a deliberate push within the UK and also internationally to take health services online prior to the pandemic, but the crisis has accelerated that shift. Despite its potential, though, telehealth is not a complete solution to the challenges of accessing and delivering care in rural and remote settings. It's likely that underserved rural and urban populations might require additional support to participate and engage with telehealth services. So there's now an opportunity to reflect and learn from the pandemic. So there's a need for evidence from evaluation studies such as this so we can understand what has and what has not worked. And this study aimed to explore staff experiences of telehealth during the pandemic in the rural county of Lincolnshire. I'll just quickly say a bit about what we actually mean by telehealth and how we define this. And there's different terms used within the literature, such as telemedicine and telecare. But in our study by telehealth, we refer to the use of information and communication technology and telephone for remote working when patients and service users are separated by distance. So we were interested in IAPT professionals' use and experience of telephone and video conferencing software to conduct appointments and consultations that would have otherwise perhaps been done face-to-face prior to the pandemic. And to do this, we used an online cross-sectional survey to ask staff about experiences of telehealth before and subsequent to COVID-19 enforced-related service changes. For those of you that don't know, I'll just give a bit of brief context about what the IAPT service is. So this is a national programme. It's been implemented in the UK as an evidence-based approach to delivering psychological therapies for depression and anxiety disorders, in line with the step care clinical guidelines issued by NICE. In England, there's now over 200 IAPT services, which renders it the largest publicly funded and systematic implementation of evidence-based psychological care in the world. And it also serves as a model globally for similar systems in countries like Australia, Canada, Norway, and Japan. In Lincolnshire, we call IAPT Steps to Change. Lincolnshire, as some of you may or may not know, is a predominantly rural county that has a mixture of urban, rural, coastal, and seasonal populations, which provides significant challenges to traditional modes of service delivery that are often based on inner city modelling. So prior to the pandemic, the Steps to Change service operated mainly from 9 sites, offering a mixture of one-to-one and group face-to-face appointments, telephone-guided self-help, and to a lesser extent, some internet-enabled therapies such as computerized CBT. So on to the results. Well, we had 62 people respond to our survey, which out of all those that were eligible, that gave us a response rate of 74%. So we were quite representative of the different professions that actually make up the IAPT service here at the Trust in Lincolnshire. Both the delivery of telehealth via the telephone and video conferencing had significantly increased since the pandemic. None of the respondents indicated a preference to return to fully face-to-face, and most, 86%, wanted to deliver IAPT fully or mostly via telehealth. There were some concerns about patients' ability to maintain attention and focus, as well as to use and observe non-verbal communication. Participants felt that telehealth service delivery required different skills to traditional in-person consultations, but more than half reported that they had not received any formal training. There was an improvement in patient attendance rates when compared to face-to-face, and there was perceived patient satisfaction with telehealth was similar to face-to-face, and almost a quarter there reported higher perceived patient satisfaction with telehealth. And in this figure here, we just have some things listed down the left. So things like ability for the patient to access services, attendance rate, timeliness of reviews, time required versus face-to-face, effectiveness of communication, ability for the patient to ask questions and clarify advice. I won't go on through the rest, but we were asking, compared to face-to-face, were these worse or better? And we can see from looking at the figure that anything there in the red or orange is where they were coming up much worse or somewhat worse. So the ability to use and observe non-verbal communications was one that we certainly picked up that clinicians felt was worse, but also maybe the time required for telehealth versus face-to-face. And some of this could be down to perhaps duplication across systems or more administrative work with this new way of working. When we look at things in the blue, so things that came up as somewhat better or much better, access services, the attendance rate, these are the two most striking ones there. But actually, we have quite a lot somewhere in the middle that clinicians felt was about the same when we compare telehealth delivery to face-to-face. Having said that, certain groups were identified as having increased challenges engaging with and accessing IAPT via telehealth. And some of the groups that our respondents highlighted were older adults, people with learning and sensory disabilities, those with low digital literacy, as well as people who were maybe in areas with poor mobile or internet connectivity. But on the whole, our findings suggest that after extended use, IAPT practitioners find this an acceptable model of delivery, and some prefer it over face-to-face. Further research is needed with groups identified as having challenges with engagement and access. And this is something that our team are actually in the process of doing. We're wanting to collect some qualitative data with patients who are having difficulty engaging with or accessing IAPT via telehealth. And there needs to be a realization that some patients will still need to be seen face-to-face, and that a blended offer should be maintained going forward. So thank you very much for listening. That has been a very quick overview of our work. We do have one paper currently under review in the Journal of Telemedicine and Telecare. Ojali, like I mentioned at the beginning, will be presenting a poster on the days of the conference. But if you would like to find out anything more about what I've said today, my contact details are on this slide. And we also have the Twitter account there for our institute, and the web address too, if you'd like to find out anything more about the wider work that the Lincoln International Institute for Rural Health is engaged with. Thank you.